Welcome to the EPIC webinar. Bruce Barnhart, Dan Spate, and Ben Bobrow here with you, and we're 1 minute till, so we're going to start in about 45 seconds. A large number of you have already joined, and so we're going to start right on time in about 30 seconds from now. Just so you know, there should be in your email, there should be a description of how you can join in the chat box to send your questions in via the chat box, and in addition, there should be a way for you to see that on your screen by maximizing the chat box on your screen so that you can see, and I believe that also is self-explanatory or gives instructions. So,
and the information to get continuing education credits, and the webinar will also be archived. So if for whatever reason you miss it today or you can't hear all of it, it'll be archived on the epic.arizona.edu website where you can read the entire thing.
In addition, if you're trying to see if you can see us, don't keep trying. It's just distracting because there's three of us and it's so small on your screen anyway. So you can minimize that box if you want to, so it won't obscure the upper right. So we're going to go ahead and get started. And as you can see here, we have scheduled about 45 minutes worth of material and plenty of time for Q&A at the end. So again, please send your questions in via the chat box.
You know, before you start, Bruce, I'll just say that this is really kind of the result of our last several webinars. And each webinar, we get more and more good questions coming in, and that's what's really fueled us to keep doing this. And so our plan this webinar is to review some of the great questions and cases that have come in.
Perfect. My name is Bruce Barnard. I'm the implementation project manager for the EPIC project. And the first question for anybody out there that is not fully informed or fully aware of what EPIC is, it is a before and after comparison of outcome from moderate to severe TBI. So we're trying to collect cases before we did an implementation of training and then after the implementation of training. We are working to implement simple interventions across the entire state of Arizona and improve outcome from traumatic brain injury and measure that outcome. We're working to link the pre-hospital data together with trauma center data so that we have a seamless record of what happened to the patient from the time that EMS got on scene all the way through hospital discharge. This hasn't ever been done anywhere else, and so far we have trained over 400 EPIC master trainers who then go out and train their people. We have 114 agencies certified currently, and that number goes up every week or two. We have over 10,000 EPIC providers that have been trained across Arizona. This is only occurring in Arizona. It's an NIH grant. We believe that about 85, almost 86% of patients are now being cared for by only EPIC-trained agencies, EPIC-certified agencies. So far, again, this number goes up essentially every day. We have over 26,000 records, 26,000 patients that we're collecting data on and finding out really interesting things that we'll be telling you about. And we have data from approximately 187 agencies. We think there's about 250 in Arizona, but some of them are very, very small and very hard to get a hold of. So with that, I will turn it back to Ben.
Okay, great. This is Ben Bobrow with Dan. I'm one of the co-PIs for EPIC. Before I jump into this, Bruce, Dan and I both want to recognize and acknowledge what you've done with all our EMS providers across the state. It's been a Herculean effort, and it's gone actually even better than we thought it could have gone, so phenomenal work. So let's jump into some of the topics. The first one we're going to talk about is sedation and TBI. This is something that's come in several times and come up several times. Bruce kind of in a pithy way titled this sedation, TBI, friend, foe, or both. So great. So clinical question that comes across a lot is, should TBI patients be sedated in the field? There's lots of real life things that are going on. Probably the most important is safety, and both patient safety and crew safety. This can be particularly challenging, especially with TBI patients that are combative, and that's, as you know, not uncommon. It's very, very common for patients that have traumatic brain injury to be combative for, because of their head injury, and then also possibly because of concomitant intoxications and ingestions. And so this is really potentially a big deal, especially in confined spaces such as ambulances and helicopters. So I know this personally. Kind of the classic approach is keep people really, really sedated, and sort of the motto historically has been, the more sedation, the better. And we kind of use the adage, you can't over-sedate a patient with traumatic brain injury. And I know, 10, 20 years ago, that was kind of our approach inside the emergency department, that we really don't want them moving or agitated, especially pulling out, IVs and endotracheal tubes, and then all the other things we just talked about with trying to transport them. So trying to keep them really, really snowed was sort of the norm. But the clinical problem with that is that when we keep people really, really sedated, almost all of the commonly used sedative drugs, especially narcotics and benzodiazepines, have a very powerful vasodilatory effect. They decrease both cardiac afterload and significantly decrease cardiac preload, as many people know. So what happens as a result of that, the real problem and the dilemma is when we cause hypotension, that can happen very, very quickly. Note it happens very, very quickly, especially in kids and in elderly people, that they just don't have the same compensatory response to shock as sort of adults, especially kids and elderly. And we don't really know who's going to suddenly plummet their blood pressure. We have no way of predicting that. I know that people that have been doing this a while, it's really hard to know who and when are going to have significant responses to even low doses of drugs like morphine and Versed. And the real physiologic problem is that significantly decreases cerebral perfusion pressure. And as the people that have been, all of our EPIC master trainers, the over 450 people that have been going around, being the champions for this, and all our over 10,000 EPIC providers know that's really the name of the game, is maintaining cerebral perfusion pressure, really at all costs. We can, yes, it's true that we can reverse the agents with naloxone and flumazenil, but the problem is those drugs work. They work on the central nervous system, but they do not reverse the vascular effects. So they will not correct the hypotension that we can cause. A secondary problem is that both opiates and benzodiazepines can lead to respiratory depression and hypoxia. This is also true, very commonly in pediatric and elderly patients, and even sometimes in just adults. And again, it's hard to predict who's going to sort of have a really profound respiratory depression response to even low doses of benzodiazepines and opiates. So at all costs, we need to avoid causing hypoxia, as we know, and we've talked about, and Dan will talk about, that's one of the cardinal sins, one of the H-bombs is causing hypoxia. So that's one of the things that we need to at all costs try to prevent and rapidly correct if it does happen. Now, we also want to throw this in. Ketamine has come up several times, particularly because ketamine is now very, very recently been placed in the drug box for EMTs in Arizona. And so, once something's in the drug box, it's very likely going to get used. There are people that are doing studies looking at ketamine for traumatic brain injury. It was sort of, historically, it was one of the drugs that we tried to stay away from because there was some data showing increased intracranial pressure. Those studies have sort of been challenged recently, and that sort of led to this resurgence of ketamine kind of coming into vogue for treating, inducing patients for RSI that have a suspected traumatic brain injury. What I can tell you is the jury is still out on this. It's really, really unclear if ketamine is a good drug, a safe drug for traumatic brain injury, if it helps or harms people. People are challenging that old adage that it increases intracranial pressure, but it's still unproven and really, really unknown. So I just want to put that out there that, you know, our stance on this is that right now we really caution people who are using ketamine for inducing patients that have traumatic brain injury. I don't know, Dan, you want to say anything else about ketamine?
Yeah, I would just say probably the single most important thing for everybody to remember now is anyone who makes dramatic, clear conclusions about the use or non-use of ketamine, they're editorializing. They are not speaking because of data. Yeah. Because we simply, what Ben said is absolutely true. We simply don't know. We suspect that the usage will go way up, but we don't have time in this setting to talk about it, but there are reasons to be concerned, and there are reasons to think it might be better than some of the alternatives, but the reality is we really don't know.
Right. So we you know, people have asked us that question several times, and that's really why we included this today. So really, the clinical question, should TBI patients be sedated? Our bottom line is, yes, patient comfort is important, but saving critically injured patients' brains trumps everything. So, you know, we're not advocating, you know, doing painful procedures on patients, but we really, really need to make sure that at all costs that we don't cause hypotension and or hypoxia. Additionally, in the setting of TBI, what we advocate is that providers try to err on the side of under-sedation with the thought that you can always provide more sedation, but it's really, really hard to take those drugs away as if they're given in too large of quantities. So that's kind of our piece on sedation. We're going to move on to another really, really hot topic of hyperoxia that we get asked about a lot. Dan, what do you think about that?
Yeah, the issue has really come in to the EPIC website from all over the world because there is such a huge movement toward being concerned about hyperoxia occurring during and after resuscitation, actually from many different causes, even cardiac arrest, etc. And so this is a super hot topic out there. And where we always start this conversation is, remember that the current nationally and internationally vetted traumatic brain injury guidelines strongly, even though the quality of the data is not great, it is nonetheless a strong recommendation that high-flow non-rebreather be given to anyone who has lost consciousness and who is going to be transported. The key really is to keep them at 100% throughout their entire course. And we've had multiple questions, and at the end we'll probably come back to this topic of the tweaking that I'll talk about in just a minute. And here's the concern, of course. Hyperoxygenation has been shown in certain settings to worsen post-ischemic cellular damage, and from a whole bunch of mechanisms that we won't go into. But it's also well known that when you're at very high FiO2s for long periods of time, it can cause ARDS, which is bad for everybody, including traumatic brain injury patients, and it may worsen a neuro outcome. So here's a question that frequently comes up and is actually starting to emerge in some protocols. And the question is, why not aim for a mid-90s range if the pulse ox is at 100% and the patient is breathing spontaneously, why not back off from high flow and just put them on a nasal cannula at lower flow? And then if you get them on a ventilator, why not turn down the FiO2 to 50%? These questions are coming in all the time and, again, being reflected in many protocols. Each time we do this, we've tried to give a quick snapshot of how important it is to understand evidence in medicine, and this is a really key example of knowing where the studies come from, the setting, the methodology, and the assumptions of the studies. And when you transfer knowledge in medicine from one setting to another, you have to try to be very careful to ask the question, what do I really know for sure, and what do I think I know, or what's the latest, if you will, what's the latest sexy thing that just came up? Here's where the evidence comes from. It comes from patients who were treated in ICUs with long, long hours and days of hyperoxygenation, and almost all of the good data actually comes from non-hemorrhagic stroke. So it has nothing to do with trauma, where the evidence comes from. Doesn't have anything to do with trauma or hemorrhage. So what's totally unknown is what very brief episodes of hyperoxygenation occurring early in traumatic brain injury. Again, this is one of those places where if somebody has a strong opinion about this, it's not an opinion based on well-established science, for sure. And what's interesting is there's some recent European information that even has some of the experts there thinking that maybe hyperoxygenation really early in TBI care may actually be beneficial. Here's the question. What do we really know about hyperoxygenation or oxygenation in early management? And here's what we know for sure. I'll show you some studies later. Hypoxia is for sure really bad. That is established as well as any medical knowledge that can be established. That's well established. And that hypoxic events are incredibly common, especially in the EMS environment. So what you have here is a theoretical risk versus an established evidence, hyperoxia versus hypoxia. And then the other thing that's important to remember is how important pre-oxygenation is. This should warm the heart of every intubator that's on the call. The reality is if you properly pre-oxygenate a patient, it is incredible how long sometimes, how forgiving, if you will, the pulse ox becomes when a person is fully hyperoxygenated, which typically in the literature means functionally in the clinical setting at least 3 minutes of high flow O2 or 100% oxygen. And so here's the key. There is now a clinical science of being very careful about giving oxygen. But it comes from, as you can see, it doesn't come from anywhere near our galaxy. And here's a brief description, as you know, of our galaxy. You have the issues of scene safety, moving patients, traffic control, extrication, moving rotor systems, and this is really important. There are lots of strangers doing complex tasks together. There's noise, light, environment. You may be in the rain, you may be in a ditch, and code 3 transportation. This is very different than a university critical care unit. So what can go wrong? Just about everything. Pulled tubes, kink tubes, disruption from your source, and then of course about a third in the EPIC population, about a third of the patients are actually flown, and so they're taken to altitude, which everyone I'm sure knows significantly changes the oxygenation issue to begin with. So here's really what our environment is like. There are a lot of unexpected hypoxic events that happen, and so this may in fact explain some of the European early studies. They're not very big and not very good, but what it's looking like in some of those is maybe early hyperoxygenation, if you will, is good, and the reality is what we're starting to think of is maybe calling it hyperoxygenation that early in the resuscitation is the incorrect way to think about it. So notice this. We're encouraging all of us to think of hyperoxygenation as actually being pre-oxygenation to save the patient from the next unexpected event. And that could theoretically explain some of the trends in some of the data, because if you can prevent hypoxia, you double the person's likelihood of survival. Here's the summary on this topic. Tweaking oxygen delivery to prevent hyperoxygenation, in my opinion, actually removes the protection of pre-oxygenation for the next unexpected event. And let me just pass this one. Here's our suggestion. Err on the high side of FiO2 even after intubation. And then here's our registered trademark, if you will. More than 100% is where we would recommend they be. And in fact, just this is partially tongue-in-cheek. If we could give hyperbaric oxygen in the pre-hospital treatment of TBI patients, we probably would at this point. And then I want to, before we move on to the cases, I want to give you, each time we do this, we're showing some of the really phenomenal findings that are happening from the EPIC evaluation, and thanks to all of you. It's all of you out there who have made available the information and the data and so forth. But these findings are brand new findings that don't exist in the literature.
I mean, Dan, before you go on, but
yes.
the EPIC, the Arizona EPIC database, correct me if I'm wrong, is one of the largest moderate and severe TBI databases with outcomes that exist.
Yes, and in fact, if you talk about the linked pre-hospital data that all of our providers are now providing, every certified provider is providing, if you talk about that, it is by far and away the largest linked pre-hospital to outcomes by far in the world.
Right. So as we're figuring out, as we're soon going to find out the outcome benefit of all this incredible work everyone's done across the state, we're already making really, groundbreaking discoveries about TBI that are going to likely change how people take care of traumatic brain injured patients all over the world.
Absolutely. So this is supposed to be a busy slide to make the point of this is a very short list of the literature that shows that hypotension dramatically increases mortality in TBI, at least double. This is a very, very short list of studies that show that hypoxia dramatically increases mortality in TBI. Essentially, every provider out there knows this if you've been received the EPIC training. But one thing that we know essentially nothing about is what about the interaction between a patient who has both hypotension and hypoxia. And Ben just alluded to the reason. There have been no studies large enough to ask that in the pre-hospital setting. In fact, as we've studied the world literature, we have only been able to find, the largest study we've been able to ever find that had pre-hospital data that showed patients with hypotension and hypoxia combined only had 14 patients total in that group. So essentially no one knows anything about it. So what we have done is, for the study of this sub-evaluation, is taking children aged 10 and greater, because then the systolic blood pressure of less than 90 for all ages above that is less than 90, just to make the analysis simple for this purpose. And then hypoxia is a SAT of less than 90%. And as you can see already, even with all the exclusions, this is almost 7,500 patients. And notice, here's the moderate to severe TBI group. Approximately 88% had neither hypoxia nor hypotension. And we're obviously hoping that that group will grow in the post-implementation. By the way, this is pre-implementation data. That about 3 to 4% have hypotension alone, but didn't have hypoxia. Almost 6% had hypoxia, but not hypotension, and 3% had both. And notice this incredibly dramatic set of mortality. So this is mortality in moderate to severe TBI patients. Notice if you take the entire population, there's a mortality of 11%. But if you're in this group, and remember, this by final diagnosis means the patient did, in fact, have moderate to severe TBI. It's only a 7% mortality in that group if they never have hypotension nor hypoxia. And you can see hypotension dramatically increases, hypoxia alone dramatically increases, but this is really a new finding. 80% mortality in TBI patients who have both hypoxia and hypotension. And so this is the logistic regression. Don't be scared off at all by the statistics here. Let me just say that what this is a technique that allows us to adjust for all of the things that impact on survival. So this includes age and how badly severely injured they were, how many body systems, a very, very complicated process. But the beauty of this is, notice what this means is hypotension only. After you account for all of the other things that impact mortality, hypotension increases the likelihood of dying by over 2.1%, as you can see. If they have hypoxia only, and this is only a single event. If they have multiple events, it's much higher. But a single event is over 3 times more likely. But notice both. This is a staggering finding. The adjusted odds ratio for the likelihood of death, if you have both, compared to having neither, is 21. And so just to put that into perspective, notice if you just added hypoxia and hypotension together, you would expect them to have a 6.7 times greater likelihood of death. But the reality is, in our findings, it's actually 21. So this means not only is their effect additive, it's probably actually synergistic. It's worse than just adding the two together. And this is why all of you out here who are working really hard to aggressively prevent and treat hypotension and hypoxia in TBI patients, this shows how incredibly important that is.
So, I mean, that's just an unbelievable
Let me take the back
statistic, Dan. But so you defined hypoxia, I just want to be clear for everybody, hypoxia by one episode,
a single
episode of a SpO2 less than 90, and a single episode systolic blood pressure less than 90.
Episode, that's right.
And as you're also finding out that maybe that single episode of 90, that might not be really the optimal target.
Oh, absolutely. And if you saw our last webinar, and we'd encourage you to go on the last webinar because it is archived. In the last webinar, what we showed is, this is really, really astonishing and also new from the EPIC database, is the optimal adjusted blood pressure for a person with TBI in our database at that point of about 10,000 patients in the analysis. The optimal was between 140 and 145. And below that, you already start increasing mortality. Now, that's not the same as telling people to start trying to treat to get the patient to 140. So don't hear what we're not saying. But as Ben said, 90 may actually be too low.
Yeah. It's just another unbelievable finding.
Okay, so let's go on to cases.
Bruce, do you want to?
Sure.
These are some great cases that we've had in the database, and we're going to try to call out and give some kudos to some of the agencies that have helped us collect some of these data.
So what we've done is we've gone out and we actually collect monitor level data second by second from a number of different agencies, including Guardian Medical Transport, Ground and Flagstaff, Mesa Fire, Glendale Fire, Sun City Fire, Peoria Fire, Yuma Fire, Southwest Ambulance.
And we're probably sorry if we forgot
missing some.
I know we've gotten data from Goodyear, Scottsdale, and others. So we really appreciate that. That data is absolutely critical because it's, as you all know,
see how incredibly helpful it is.
Yeah, as you all know, it's very difficult to write down everything that happened during a call, every single blood pressure, every single pulse ox, every single end-tidal CO2. So what we've been able to do is actually go back and see exactly what happened. And what we've seen is fairly good correlation between what the medics are charting and what actually happened on the case, which is phenomenal. And we're able to reconstruct the case and construct plots that show exactly what happened. First thing that we need to talk about is we have to be incredibly careful if we choose to intubate the patient. We have to be incredibly careful not to hyperventilate them because it makes it so much easier to do so. Spontaneously ventilating patients may hyperventilate themselves, but we don't have a hand in it. When we intubate them, we then can control that and we can overventilate them, which happens commonly. Synopsis of this case was a 38-year-old male motorcycle crash, no helmet. He had extremity fractures. He had an obvious TBI. Blood pressure was elevated. GCS was 3. They did spinal precautions, put him on high-flow non-rebreather mask, started an IV TKO. Pulse ox kept at 100%. They were a fairly long distance from the trauma center, and they decided to intubate. And this is the graph, minute by minute, of what we saw after we looked at the data. And if you see...
Yeah, let me just pipe in on this, and you guys can too. This is incredibly instructive. This is remarkable. I believe this was either Yuma or Glendale Fire. I think it was Glendale. Just absolutely remarkable case. Notice here several things. First of all, notice the concept. Any of us who have intubated know that concept of the tube goes in. The first thing you do is you high five somebody, and then you say, okay, bag them up, right? Notice here how little hyperventilation it takes in order to get the patient to have a CO2 that's low. See how they quote, bagged them up? Hardly. I mean, they only got up to a rate of about 15, and already you can see very, very low end-tidal CO2s. But what's really dramatic here is how carefully this Glendale medic immediately identified the low end-tidal CO2 and started decreasing. The other thing is, as you look out to the right of this, notice how hard it is to bag a person slowly enough to get their CO2 where it ought to be. This is very, very counterintuitive to all of us. And by the way, It is worth noting a nuance here, and I'll let the other guys pipe in after I finish this. A nuance here is if you do get down to bagging a patient at, say, 5 or 6 a minute, you should make sure that you have good blood pressure, which you can see this patient had a blood pressure of 163/113. So this is definitely not shock, because obviously decreased blood flow to the lungs in shock can also decrease the end-tidal CO2. So what's really dramatic here is they got this person way down and were able to bring the end-tidal CO2 up to 40. Guys, other comments on this?
I would just say that this Glendale Fire and Southwest Ambulance crew, they're the ones I want treating my TBI. Because they knew exactly what they were doing. They responded so quickly. They were using the end-tidal CO2, so effectively, and it's like we've been saying for a long time, doing intubation or advanced airway maneuvers and with manual ventilation without end-tidal CO2 is worse than BVM, than basic airway maneuvers. It's just too dangerous.
Yeah, the way I like to say it is, if you're going to intubate but not do proper post-intubation ventilation, then ALS is a downgrade from BLS. Right. And I think the literature massively supports that concept.
This graph tells it all right here.
And the interesting thing that we're seeing is we are seeing in the EPIC database a decrease in intubations, which means that the providers appear to be considering their choices and being very careful with when they intubate. So that's been very interesting to see.
Okay, so here's the pay attention, if you will, or the take-home. The target, everybody remember, target is normal. It's 40. It's really hard to prevent and correct hyperventilation. We see here how difficult it was, how low they had to go to get
it. Last one, the ventilation rate was about 6.
Yes, that's exactly right. And then the other thing we're really encouraging people is whoever is doing the bagging should clearly be paying very close attention to both their rate and their ventilation rate timer and their end-tidal CO2. But we strongly support that if there's somebody else at the scene who can actually be the one who watches the bagger and watches the end-tidal CO2 also, to tap them on the shoulder when they're going too fast. All of us need that. So we're really strongly suggesting we call them the watcher. That there should be a watcher who taps you on the shoulder saying, hey, slow down.
Right.
Okay, Ben, you want to talk about this one? I know you're very familiar with this case.
This is a phenomenal case. We called this TBI on the freeway in a thunderstorm, rainstorm. This was a case pretty recently. This one came in from Mesa Fire and Southwest Ambulance. The basic synopsis is a 47-year-old. Again, the last one I think was 38-year-old. The average, again, the average of our TBI patients that Dan showed was 41 years old. So these are really, young people, often in the prime of their lives. Just
one point, Ben, that's important. It's bimodal. So the reality is there are a lot of elderly ones. So the reality is if you exclude the elderly, then the median is down in the mid to high 20s. So you're right. It's really bimodal. So absolutely, it's a remarkable number of young people who get this.
So this is a 47-year-old man who was involved in a high-speed motor vehicle crash on the freeway in a rainstorm. He was ejected. When they found him, he had very slow respirations. He was quickly pulled actually out of a ditch, from the rain, and placed on a backboard, C-spine precautions. His ABCs, his airway was gurgling and snoring. His teeth were clenched. This was a really challenging case. This is a challenging case under the best, environmental situation, and this was probably the worst that you could imagine on the side of the road in a rainstorm at night. His teeth were clenched, so the medics were not even able to open his mouth enough to place an oral airway. His breathing was decreased. They thought that there was even maybe some decreased breath sounds on the right side. He had good pulses. His initial blood pressure, though, was low, and so we know that the bottom floor is a systolic blood pressure of 90, absolute bottom, and he was obviously, getting really close to that. His GCS was 3, as you see there. He was just moaning to painful stimuli. He had a large scalp laceration, some other wounds that they noticed. They got an IV started, peripheral IV, and got 1,200 cc's of ringers in immediately. Because he was so sick, they decided to proceed with RSI, which was done. This gentleman then had a flow control bag was used. This is one of the smart bags that we're using in a lot of our systems, and ventilation rate timer was documented. And then he was transported. All of this done, which I'm amazed that they got all this done so efficiently, so quickly. The on-scene to hospital time, to the trauma center time was about 25 minutes, which is really, really phenomenal. He did, it's not documented there, but he actually, in addition to Tomidate and Sux, he did get some Versed as well, which I think becomes interesting, and these are his graphs. As we look at the minute-to-minute end-tidal CO2, as you can see again, it's right in that sweet spot. So these guys just nailed it. They nailed the ventilation component of this patient's TBI care, and when we see these cases, it's just it's unbelievable for us to see how meticulously people are managing ventilation now and really watching the end-tidal CO2 so carefully. As you look at the graph on the bottom, you see that first systolic blood pressure of 96, right? So we know that this guy is likely in shock, and we're really, really already concerned. I showed you that he got some fluids right away to try to mitigate the hypotension, and so you can see the different data points. What's interesting, and I think it likely is really clinically relevant, is he did get some drugs, some sedation to do the intubation, and there was, as you see, a systolic blood pressure of 68 right after the intubation. I don't think that's a coincidence. I think that most likely this patient was in shock. He got some sedation, and this is really what we talked about before. Is all those sedatives, both benzos and opiates, can very, very quickly cause iatrogenic hypotension, especially in a patient that's already in shock. So that did happen, as you see here, but it was very quickly addressed and corrected with more IV fluids. You see the subsequent systolic blood pressures, 128, 113, 109. One thing I'll have to say that when I see this, and we didn't see this when we started, this guy had 5 sets of vital signs done. That I don't think was the norm. And so, we're seeing all kinds of sort of offshoot benefits from the EPIC training. But one of the things, besides the incredibly meticulous ventilation treatment that he received, this guy had 5 sets of vital signs. These medics were on it. They were monitoring everything and documenting it really, really closely.
And responding.
Yeah. Really, really closely. So you can see that the patient, this is a really, really sick guy, and he was hypoxic from his severe head injury. They addressed it, they corrected it, and you can see that the subsequent minutes of his care were monitored very closely, and both the end-tidal CO2, the ventilation, oxygenation, and his blood pressure. I don't know if you guys want to
Bruce wants.
Yeah, that hypoxic fall during the intubation is so common with RSI. We're seeing it more often than not. And pre-oxygenation is the best thing we know of that will mitigate that or help minimize that. We've seen that in most of our RSIs where we see a big fall briefly while they're trying to get the intubation. So really watch for that. I'd recommend having somebody watching the pulse ox and the monitors while the other person is intubating so that you can pull out and rebag the patient up.
There's been some great cardiac arrest studies looking at how long it takes us to intubate patients under these types of really, really, really challenging conditions. And it always, first of all, it takes roughly a minute, on a minute.
Yes.
So lots of cases can take much, much longer, but it always, when they go back and ask the people doing the procedures, they're always underestimate how long it took, by minutes. So, this case really demonstrates all those things. Just to recap, the ventilation control was beautiful. The monitoring was phenomenal. He did have this episode of
of hypotension that we think was likely related to the intubation and the drugs, and he did have this episode of, fairly profound hypoxia that was likely related to that intubation. These guys addressed it, they corrected it as quickly as possible, but these are the things we really have to watch out for.
Absolutely. But let me just make one last comment. Having spent my entire career, now more than a quarter of a century, in the trauma center, when I get to the end of this, I think, holy cow, these medics are doing this better than we do.
Yeah.
And so what's remarkable, and you've heard this before, we are so grateful the fact that what we're starting to hear now is the medics and the EMTs are coming in and they're schooling the hospitals saying, hey, we kept this guy alive till now. Don't go toasting him off now. So you're actually helping move the guidelines honestly into the hospital by your meticulous nature in cases like this.
And the trauma centers are taking notice.
Yes, they are.
They're seeing that actually the pre-hospital systems have implemented and are actually pulling off things that sometimes in the trauma centers, I hate to say,
it's hard to do.
They're just not doing it yet.
Yeah. So, Ben, just a comment on this. Isn't this gorgeous?
And I just want to show this quickly. These were the perfect, end tidal, flow capnography graphs that just were quintessential, just perfect, and that's exactly what you want to see. In addition to the rate and the end tidal CO2, what we don't want these really high peaked end tidal graphs that show, very brief high pressures. What we want are these kind of slow over 1 to 2 second type of capnograms. So we just wanted to point that out as well. So really great. Again, these guys nailed it. So again, this is exactly what we want to see. So kudos to both Mesa and Southwest Ambulance for those things we talked about, the incredible meticulous documentation, the treatment of hypotension and hypoxia quickly, and the use of the actual the devices and the techniques that we've been working with people to implement. And so this case had it all. And again, they had it all under really challenging conditions.
Incredible.
That's why we want to show that one. So we'll just press on. We do have we're trying to get out to people. Providers were really interested in getting an app. So we now have, through the Epic website, you can get the free Apple or Android version of the Pocket TBI app. And so this has all the condensed Epic protocols and algorithms and targets. So if you just put this on your phone and you can keep it, this is a great reference tool. You don't need it. When we first started out a couple years ago, we had laminated cards. So you don't need those anymore. You can just download this stuff. I do want to thank the Ramsey Social Justice Foundation. There was some cost for us to do this, and they were very gracious about doing that. So I want to acknowledge them for that. Yeah. So both Rural Metro and Ramsey Social Justice Foundation helped us get that done.
And many of you have benefited from that. If you've become certified and you are willing to take them and use them, you've actually received the free adult NPs for each of your units to get started.
And the smart bags.
Yes. Take-home messages today. Be conservative with sedation. The cases really nailed that. And so err on the side of under sedation.
You can always give more.
Yes. Give tiny aliquots because you can give multiple doses, small doses. By the way, Ben and I always give the disclaimer, we're not your medical director, but so you obviously need to interact with your medical directors on these issues, but this is very significant. Be liberal with oxygen. Remember, I'm encouraging people to stop talking about hyperoxygenation in the pre-hospital setting. In my opinion, you can't hyperoxygenate. If somebody asks, why are you giving them 100% O2, my answer is because I'm pre-oxygenating them to prevent the next unexpected hypoxic event. Aggressively, remember all 3 H-bombs, so here we saw aggressively prevent hypotension and hypoxia. Remember that separately they're bad, but together they are absolutely devastating, synergistically devastating.
So I want to make the one distinction. So we want you to be really aggressive with fluids and really aggressive treating hypoxia, but conversely we want you to be ginger with the bag.
Yes.
We want you to actually squeeze the bag lightly. Treat that bag, basically, think about the patient's brain, being an egg. and it's very fragile. So you don't want to squeeze that bag too hard or too fast.
And remember, these are very simple things, but they're not easy to do in practice. We know that. We've seen it over and over again. In my practice, I've been guilty of all these sins over the years. It's very hard to do this well. So always have somebody watching you, supervising, checking your ventilation rate, managing the patient with you. Work as a team. It's really, really difficult to do this well.
Okay, and then finally, be cautious with intubation. Evaluate all of your options before committing. By the way, I believe last time we showed at the university we're part of one of the large national emergency medicine intubation databases. And what's interesting is in the best of circumstances there where we have all of the adjuncts, all of the flex scopes, everything, at U of A we published this last year. If you go from one attempt of intubation to a second attempt at intubation, the significant complication rate triples, and that's in the best of circumstances. So if you're committed to intubation, go to rescue early, and sometimes even consider your rescue device as your primary device if it looks to you like it's going to be a really hard intubation. Contact us. If you're certified and you haven't gotten your bags yet and your VRTs, contact us at the website.
Yeah. Bruce, you want to say anything else about, we do have equipment still.
Yes, we do have smart bags and both pediatric and adult, and ventilation rate timers, both pediatric and adult.
And those were actually donated by Rural Metro and the Ramsey Social Justice Foundation. So that is part of the carrot for getting the agencies to be EPIC certified. So you will get those if you're certified. Yes,
and by the way, it occurred to me that some of you have not yet gotten approval or have not been able to set up the procurement issues to get the smart bags so that you're going to keep them. And so if you're in that position where you don't yet have smart bags, there's still no reason not to put the VRTs on your current bags. Because your current bag, it will help you if you have the rate timer on the bag, it will help you to bag more slowly.
Yeah. So again, this is a partnership across the entire state with the university, the Department of Health Services, the Arizona Ambulance Association, the Fire Chiefs Association, and the fire districts, and all the EMS providers across the state.
Yeah, we just found one agency that had been certified for a long time and got lost in the cracks, and they didn't get bags, and they emailed us about it. So they got bags. So if there's any others of you out there that are certified, please let us know. We will get you smart bags and ventilation rate timers. And if you have watched this presentation and would like paramedics or continuing education, please contact Octavio Perez. That's his email address there. You can also go to epic.arizona.edu.
Can you see it?
And you can request it through there, and we'll send you a continuing education form. If you'd like others to watch this presentation, this will be archived on the epic.arizona.edu website. Be available going forward. One question that we had was
you know what, let me start with this one that just came in. I think it's helpful. The question is, given what you have just said about optimal systolic blood pressure, when can we expect guidelines to change? That's a great question. And in fact, the first comment I want to make is it's really important for everyone to understand that when we are publishing and announcing these new findings in EPIC, because nobody's ever had this size of a database to actually find these things, that's very different than saying we have done a randomized study comparing treating at 90 and treating at 100 and treating at 110. We believe that those kind of studies will be spurred by what's happening in EPIC, but we're obviously not in a position to all of a sudden say, okay, we changed the guidelines. The guidelines belong really to the Brain Trauma Foundation, which includes the input from experts all over the world and many stakeholders and associations. Since it has been approximately 6 or 7 years since the last EMS guidelines, I would not be surprised if the Foundation and NAEMSP, National Association of EMS Physicians, does a new review. And if they do a new review, it's interesting that in those guidelines, they already forthrightly stated previously that 90 may be too low. but for right now we haven't changed it. We just think it's certainly foolish if someone has dropping blood pressure and it looks like they're going to be headed down. It seems to us that may be an appropriate time to consider with your medical director treating that patient. Then the other question that came in was, when's the answer about the safety of ketamine going to come in? And personally, all I'm aware of is there's a lot of clinical studies going on, but I am not aware of any answers. Ben, any other addition to that?
Yeah, so it's a great question. So the studies, at least that the peer-reviewed studies I've seen, are in different settings. So first of all, they're not pre-hospital studies, they're in-hospital studies. Many of them actually done in the operating room or in the intensive care unit for patients that have intracranial pressure monitoring being done. So unfortunately, we just don't know right now. So I'm not saying it won't turn out to be a good, safe drug for induction of traumatic brain injury patients. But our point, as we said earlier, is it's early, and there are no large randomized trials that are looking at actually comparing inducing patients with ketamine for severe or traumatic brain injury. So,
Ben, let me have you respond to this question, and then Bruce and I will pipe in as well. Another great question. Do you advocate for routine fluid boluses before sedation, if possible, so as to avoid hypotension when the meds are given? And do you recommend that even if they have a relatively high systolic blood pressure to be protective?
So I think
great
it's
question.
a phenomenal question. So what we've shown you is that dropping below 90 is incredibly dangerous and associated with very high mortality. So what I would say is if there is any risk of a patient, if they're even close to 90, that I think it's a really good practice to sort of front load or preload patients with IV fluids before you give them sedatives that will most likely drop them even further. So I actually think that is a good practice to do.
Okay, man, the questions are coming in like crazy.
Yeah,
this is great.
I actually want to point out that I see that one of our real champions, one of our EPIC champions, has sent some of these key questions in, Dr. Gamer.
Yes.
I just want to say, I want to acknowledge that Dr. Gamer's been we really could not have done this without Garth and his, and his influence and support from the rural Metro Southwest Ambulance side and from the different fire services that he provides medical direction for.
So here's another great question that came in, and by the way, this is another one of those where literally no one in the literature knows the answer to this, and we're in the position to start asking these questions. What does the data show for patient outcomes concerning the duration of a hypotensive episode? And here's the problem. You can go to the MTOS, the Multi-Trauma Outcome Study, which has been the kind of renowned trauma database in the world, has more than 150,000 patients in it, but it all comes from trauma centers, and if they have a pre-hospital blood pressure, they have one single blood pressure. So the reality is even the massive databases in the world are unable to answer a question of what happened over the period of time in the pre-hospital setting. And what's incredible is because of your documentation and because the NIH has funded our being able to collect all of that data, we're right now beginning to be able to unpack questions exactly like that. What if it was a long hypotensive episode?
And trust me, we've talked about this very question about duration
and dose.
Duration of hypotension, duration of hypoxia.
Yes.
So we're thinking along the exact same lines as this person that submitted that comment. We will eventually be unraveling some of those key issues.
Yes, and our intent is to continue to have the webinars because we want to be able to get this to the providers faster than we can write abstracts for the scientific stuff. By the way, no one knows the answer to a simple question like, is it worse to have a blood pressure of 85 for 10 minutes or to have a blood pressure of 60 for only one very brief period of time? Nobody knows the answer to duration versus depth and so forth, and you're giving us the very data that will help us to answer that question.
Yeah.
So I think we're just about ready to wrap up. Any final thoughts or comments, Bruce?
We have some other questions. We will combine those and send them out, attach them to the webinar. We will get them answered and get those results out to you, so everybody's question will get answered. We don't have
and
time
likely,
for all of them.
right, and likely the next set of questions will be the basis for our next webinar. That's what we've tried to do, so that's what's fueled each of the webinars. I want to say, you know, we had 75 attendees on the webinar today, so that's phenomenal.
Yes.
Please tell, you know, we still want to send this information out to as many people as possible. It'll be archived, so you can view it in its totality later and even get continuing education credit. So if you thought this was helpful, please distribute it and disseminate widely.
Thanks, everybody, and take great care of your TBI patients. Remember, question whether intubation is the only answer, and if you intubate, the way you will save them is by proper ventilation.
And you are clearly changing the way traumatic brain injury patients are going to be cared for around the world.
All right, thanks, everybody.